now invite Dr. Santosh Gopi Krishna for his talk on new insights into DME and DR management via biomarkers.
Good morning all. I thank the chair and Dr. Pish for this opportunity again. So it's a little dry topic. I'll try to keep it crisp and try to make sense of it, of whatever I can understand. So I'll be talking about newer insight into DME and DR biomarkers, management through biomarkers. So one second. So when we come to the definition of a biomarker, it should be measurable, it should be predictive of outcome, and it should aid in prognosis of the therapeutic response. So it should be a valuable tool in detecting the earlier stages of the disease, tracking progression. So, but if you look at the data, the demand from the biomarkers have changed really from it has to be prognostic and meaningful, and whereas it should be effective surrogate of management as well. So DR is a very complex pathophysiology, as we all know, including oxidative stress and blood-retinal barrier and neovascularization. So when you look at DME and PDR, these are two complete different pictures. Inflammation is more in DME, whereas angiogenic factors are more in PDR. So if you look at a normal non-diabetic retina here through the Muller cells, throughout the substance of the retina, and when you compare it to the diabetic retina, so there's lots going on. I mean, there is immune cell activation, there is gliosis, there is endothelial cell damage, there is vascular basement damage, and including neurovascular coupling changes also. So all this contribute to diabetic retinopathy and diabetic macular edema, which can be irreversible, and it can be really difficult for the vision to improve at times. And when you talk about inflammatory biomarkers, we also need to see the angiogenic activators and inhibitors, which maintain a clear balance, which is extremely essential for the healthy functioning of the retina and vision. So these are the healthy conditions, and in diabetic retinopathy, you can see the rise in these cytokines and chemokines and adhesion molecules, and this in turn increase the inflammation and retinal cell apoptosis and neovascularization. These are the known systemic biomarkers for diabetic retinopathy, and these are the ocular biomarkers that are known for diabetic retinopathy, including CRP, TNF. These are the initial biomarkers, TNF and interleukins, and then comes VEGF and PEDF. So this is how cytokines are mediated. These are meta-analysis of different papers that have been published over a period of time. You can see lots of work have been done on VEGF and all these interleukins. And even if you look at targeting inflammation also, corticosteroids, as we know, are the mainstay, the Oracort and even the dexamethasone. But even liftigras and other things are also being tried, and there are different levels of clinical trials. So many articles have been published over a period of time which show that IL-6, VEGF, and these are implicated in these conditions. There are articles which even talk about we should look beyond VEGF in the causation of this problem and progression of this problem. Even adhesion molecules also are extremely important. And there are studies which have shown that different types of macular edema have different types of in these cytokine biomarkers. And even there were studies which showed that IL-1 RA was increased in these macular edema biomarkers. So even ICAM, there is a gene polymorphism which says that when ICAM is increased, they are also prone for more diabetic retinopathy and DME. And even these soluble factors, the CD4 also is raised, especially when the patients have activated microglia and HRDs. So these are again different papers suggesting what happens in a vein occlusion, what happens in DME, and when you see a flare in aqueous also, these biomarkers are also raised. So these are the known molecular signatures, but we have only few available agents that can be injected safely, though lots is going on and research and all. So these are the newer treatment options. If you look at the newer treatment options, they are going beyond VEGF. It's targeting the basic pathology, like including the basic inflammation and even the inflammation cascade and all. By the time it comes out, there might be time. So if you look at our biomarker research at Narayan Nethralaya, this is how we go about. We have the way of doing the aqueous and vitreous humor sampling, even the serum and the tears as well. Then we store at -80. Then we do the ELISA testing, and we have this. So these were the initial tests wherein we found there was a good correlation between aqueous and vitreous, so that we can easily say that, okay, we can use aqueous also to determine these biomarkers. So this is how it goes. You can do a molecular profiling initially through aqueous or vitreous tumor, and you can see the severity of DR, types of DME, and the treatment outcomes. Then you can go in and see the vitreous biomarkers and what happens in control cell versus PDR. In vitro models, like you can have HUVEC cells and RPE cell line, and you can inject these biomarkers, and you can have the anti-agents, and you can see the response, and even the mouse and animal models. So these are different results of what we found in different patterns. This is very clear cut to show that these are increased in PDR cases. Then again, in aqueous vitreous samples, the changes there. ICAM is one story what our lab is really interested in, because the cell adhesion molecules, it changes the endothelial dysfunction, and it is really associated with PDR, and especially in poor response of macular edema. So if you look at RPE cell line, you can see the difference between normoglycemic and hypoglycemic. You can clearly see that the ICAM is increased in hypoglycemic states, and when you kind of subject these RPE cells to the TNF, you can see the rise in ICAM as well as IL-6, and this rise is still persisting even beyond 24 hours. And if you look at these biomarkers, I mean the cytokines, when you inject on RPE cell line, and if you kind of see the second graph here, so when you subject it to TNF, the VEGF is not increasing, but the ICAM is increasing here. So it clearly shows that there are other molecules beyond VEGF we need to really look at, and these are the few studies that we have published so far. These are molecular proteins which are increased in diabetic retinopathy. This is beta A1 crystalline, which is high. I mean, this is a protective factor, but when you kind of cut off these factors in mice, you can see the increase in the inflammation and all. So this shows that this is a different pathway where that also can be targeted in diabetic retinopathy. Decorin levels, it's a small leucine-rich proteoglycan, and these are elevated in severe groups of severe forms of DR. And this is another paper wherein we had seen the STING pathway, and when you kind of subject these things in a mouse model, you can see that when the STING pathway is kind of aggravated, you can see a drop in pericytes, and you can see the changes in the vascular curvature also, and there are inflammatory cells that happen in the mouse model. Then again, this is another paper that talks about multiple gene products, mRNA, which has a role in glycolysis and angiogenesis. So this also can be a potential target. So if you see here, if that is kind of induced under hypoglycemic state, there is an increase in inflammation and increase in VEGF as well. So this is the biomarker pathfinder, which is a portable machine that we can measure 8 biomarkers, which is indigenously developed in NN. So this is how it goes, and we take these samples, and it's an immediate readout that you get once you place it in the machine. So we have tried to see, these are the new things that are going on. We have tried to see these biomarker, what really happens when you kind of subject AI to these. These biomarkers are taken initially, and there's a training phase where you take few controls and naive DMEs. And then again you have a testing phase when you get these suspect eyes. Then again these are the patients who have diabetes but without no clinical DR. These are all the cases wherein aqueous is taken during cataract surgery. And further, lastly, finally, we validate with eyes which have DME with a DR and without DME. So this is how it goes. So you can see the AI prediction that control is good over here, but DME again there is a change in this thing. But what we had seen is the biomarkers that were raised by ICAM and MMP9. See, these are the cutoff values. So when we had seen a cutoff of VEGF and MMP9 and ICAM, so we label these as vascular disease suspects. These are the suspects wherein they didn't have a diabetic retinopathy. There was a chance of developing a diabetic retinopathy and diabetic macular edema later. So then we subjected it to further validation. There was a risk group, and then again we classified this as risk group, and finally we went ahead and checked these with the earlier predicted models which already had high increased biomarkers in a DR and DME patients. So this is a retrospective analysis. So what we found is these risk eyes, So these risk guys, almost 16% progressed to diabetic retinopathy when they didn't have a diabetic retinopathy. Out of those 16%, we could see this 68% progress to severe forms of diabetic retinopathy, whereas 31% progress to DR with the DME. So when you look at these biomarkers, even before DR sets in, maybe during a cataract surgery, that can give an indication what is the chance of developing a DME or a DR. So this is AI-based stratification. So this is a vast study wherein Dr. Chaitra had presented recently. We kind of correlated these biomarkers across aqueous, vitreous, serum, and tears. I'm just finishing last few slides. This is a cluster map. So we found that there was a good correlation between vitreous and aqueous. And when you compare these four, the correlation was 28%. So coming to the conclusions, we need to look beyond VEGF to treat these patients, but obviously R&D and the time these drug comes out, it's quite some time. So these are the known biomarkers which can cause increase in severity, poor response to treatment, and this is basically a complex interplay of soluble factors. So this can be maybe considered in the future. So this is ideal biomarker, which is one which disease comes through and where an intervention kind of alters the disease as well. Thank you so much for your kind attention.